first speaker is Dr. Richard Schloeffel, and Richard graduated in 1978 from New South Wales University with postgraduate training in isolated rural general practice. He worked in country practices for 13 years and spent 5 years working in the developing world, including Papua New Guinea, China, India, Bali, and Eastern Europe. For the last 20 years, he's been the principal at Pymble Grove Health Centre, where he has been treating and specialising in the complex and chronic disorders with an integrative team of practitioners. This broad experience has been invaluable in developing the diagnosis and treatment of chronic disorders and the ability to look beyond existing paradigms to a deeper and more profound understanding of complex diseases, particularly chronic fatigue syndrome, borreliosis, thank you, and its co-infections and autoimmune disease. Dr. Schloeffel has treated over 3,500 patients with chronic fatigue syndrome and related disorders, providing diagnosis and appropriate investigations and management protocols. He's lectured widely on CFS and is currently undertaking research at Sydney University into Australian Lyme disease. Could you all join me and welcome Richard?
Can you hear me down the back? Now, can you put my slides on? Yeah, thank you for inviting me down to Victoria. You've provided the best weather as well, which is nice. It's not windy, it's not raining, which is very nice. My journey started with chronic fatigue syndrome in 1981, and I was fortunate enough to be working in a small country town in northern New South Wales called Cellular. And I had a couple of patients presented with very unusual fatigue, and one of these ladies was a professor of English at University, and she had very severe dysbiosis, and Henry Butt's going to talk about this later. But when I diagnosed this lady with this dysbiosis, which was a term that I hadn't heard before, she had a whole complex of symptoms, and over the next 7 years we managed to get her better. And that sort of put me on the track of saying this is a really interesting area of medicine and we don't know much about it. At those days I had to make my own probiotics. There was no such thing as probiotics. So basically I've treated those 3,500 patients, but I've probably influenced a lot more other people because now I've got a whole team of practitioners that I'm working with, and not only doctors but naturopaths and osteopaths, and I've got psychologists working in my practice, and a really dedicated team of specialist doctors who work with me to help understand these complex patients. And when I finish talking today, and I'll give my last, the last part of the talk is just a case study of a typical patient that I see, and you'll be amazed how difficult and complex these people are, as some of you may well be in this room. And my particular interest has been in this area for 20 years, and in 2005 we attended a conference in Adelaide, and basically we adopted the Canadian protocol for treatment and diagnosis of chronic fatigue syndrome. Up until then, the biggest problem we had was that people kept thinking this was a mental or psychiatric illness. As soon as I hear that from a patient, I know they've been mistreated. This is a physical, pathological disorder with a pathological basis. Mental symptoms are manifest, but that's not the cause of the disease. And when I hear that, I know that they probably haven't had any good treatment or diagnosis by the time they got to us. So we basically adopted the protocol, and basically that took out depression. So in New South Wales, I'm not sure about Victoria, it's still gazetted under the Mental Health Act, chronic fatigue syndrome, but that just needs to completely disappear because this is a pathological, disturbed physiological disorder. And the primary things you're looking for is fatigue that's unrelenting, unrelieved by rest, that persists for more than 3 months in a child and more than 6 months in adults. This is the protocol. That there's post-exertional malaise or fatigue, which if those who suffer this will know about. It's that unrelenting fatigue when you've got out of bed and gone to the bathroom and you've got to go back to bed again because you're absolutely shattered by that process, or you've been able to do one thing during the day. So it's sort of an unnatural lack of recovery from any normal activity. The sleep dysfunctions, the circadian dysrhythmias, the reverse sleep patterns, people sleeping during the day, awake through the night, not sleeping at all, or hypersomnia where you sleep all day. Pain, headaches, myalgia, muscle pain, joint pains, neuropathic nerve pain. All those things are manifest with this disorder. All the cognitive and neurological symptoms, and often people do have mental symptoms, behavioural problems, and learning difficulties and memory and cognitive stuff, because that's the brain's disturbed. And I've been able to measure what's happening in the brain with some of my research, and at least some of these, all these other things, these neurological and autonomic dysnomias, I call them, all the gut disturbance, the cold hands and feet, the POTS syndrome, postural orthostatic tachycardia, fast pulse, dropping of the blood pressure, that some of you may experience, and generally is a common problem. The case study I'm going to present has all these. And then it's persisted for more than 3 months in a child, 6 months in an adult without a known cause. Now, you've got to get a differential diagnosis. Now, most people presenting to me with fatigue, people wait 6 months to get in to see me. I spend an hour and a half with a new patient. And 10% of the patients I see don't have chronic fatigue syndrome, ME. They have something else. So it's really important as physicians, but as patients, to make sure your doctor's actually worked out, or your naturopath, or whoever's looking after you, that you don't actually have something that's treatable that's just been missed. So I won't go through all these because I am limited for time, but basically there's a whole range of, you'll hopefully get a copy of these slides, but basically there's a whole lot of things we need to look for before you actually make the diagnosis of chronic fatigue. And you get that by taking a complex, detailed history. So for us as physicians, it's really important. If you go to your doctor and he gives you 5 minutes, you're not going to work out the patient with chronic fatigue. You need an hour, hour and a half. Some people use questionnaires, whatever's required. But there's a whole range of autoimmune, cardiological, hematological, blood disorders, all medications people are on. As I said, I won't go through this. And many things, all the metabolic disorders, neurological, neuromuscular disorders. I have people presenting with multiple sclerosis, being told they've got ME, they've got chronic fatigue syndrome, and many of those patients actually have borreliosis, have Lyme disease. So you've got to be very careful that you just don't say, I'm multiple sclerosis, and then they send off to a neurologist and don't receive the right treatment. As I said, there's lots of other factors, and also always we've got to look for malignancy, we have to look for heavy metals and other chemicals, pesticides, huge problem in Australia, huge problem in America, probably Europe as well, as a cause or an underlying cofactor in why people get sick. This is an emerging illness, and there's more and more people getting these disorders all around the world. And it's because we've changed the environment that we live in, whether it's global warming or pesticides or heavy metals, whatever it is, our food chain, everything's been disrupted and disturbed, and we're all supposed to cope. And there's certain people who have possibly genetic predispositions, which I'll talk about shortly, that means that group of people don't cope as well, and they develop chronic fatigue syndrome. Okay, when you're investigating this, your doctor, or if you're a doctor here, you need to do all the general things, all the usual tests that, full blood counts, liver tests, kidney tests, check for iron and B12 levels, check for simple things like celiac disease. Now, I diagnose celiac disease all the time, and often these people have seen 20 other specialists and all sorts of doctors, and they haven't done a simple genetic test. So 1% of people who carry the gene have celiac disease, but 30% of people with the celiac gene have gluten sensitivity syndrome. They might as well have celiac. They cannot eat gluten. And they can't actually eat the other foods that are related to gluten as well. And there's a wonderful researcher down here in Melbourne who's done some work on the FODMAP diet, which is highly useful in some of the patients that I see, where you take out a lot of oligosaccharides and fructans and things which are associated with gluten. But there's a whole range of things you need to look for, and you need to exclude a whole lot of infections. But when you're looking at these disorders, there's so many things on this list, but I look at viruses, I look for mycoplasmas, chlamydias, rickettsia, and then all the borreliosis, that's Lyme disease. For some of you have been overseas, and you may well pick this up from a tick bite or something else that bites, and causes disease of unknown cause, unknown diagnosis, and we need to actually pick it up and make sure that you get thoroughly investigated. So some of the most useful tests, once you've excluded all the other things, is I start looking for infections. So if someone presents to me with a whole range of symptoms. And the symptoms can be incredibly difficult to differentiate because you've got lots of multi-systems affected. You've got headaches, you've got muscle pain, you've got all the gastrointestinal disturbance, you've got lung problems, palpitations, headaches, collapsing, you may well have arthritis, sleep disturbance, cognitive issues, so many different issues, and they don't seem to relate to each other. And that's because it's a multi-system, multi-dysfunctional disorder, and lots of your body is affected by this. So I really look at some of these tests, and once I've worked out that we haven't got chronic illness other than something that looks like chronic fatigue syndrome, then I really start looking for the most obvious cause. Now, the most common cause of chronic fatigue syndrome is mycoplasma infections. I think that might be controversial, but I do PCR testing, and I find so many of my patients have this atypical bacteria within their cells, which you can measure through PCR testing, and I'll show you some slides later of some of my work. And that's why the treatment that I offer actually works, because if you've got disrupted cellular function, chronic fatigue syndrome is a cellular disorder. So you've got the cells mitochondrially being affected, and as a result of that disorder, in each cell, the collective dysfunction of those cells causes all your symptoms. That's what chronic fatigue syndrome is. Okay, so there's a colleague of mine, Professor Garth Nicholson, who was involved in the Gulf War illness back in the 1990s. And he was very influencing on my thoughts about this, because I knew there was an infection. I started looking at this in the 1980s, and I was treating AIDS. And then it became too complex because then other drugs came around and I could prescribe those. And I was really interested in HIV and tuberculosis and leprosy. And I said, there's got to be an effective basis for this, because why have so many families got this? Why do people get an illness that looks like a chest infection or a throat infection, and then they become unwell and they progressively don't get better? So he developed this PCR testing, polymerase chain reaction test. So you take some blood or urine and you fractionate it and you look for the genetic structure of these organisms and compare it to a known normal. And if you get a positive result, and the lab that I use does 4 tests for every patient to make sure that it is accurate, the results we get. And we find mycoplasmas, chlamydia and pneumonia, which is a lung-borne, these are lung-borne infections, you breathe them in. And then they systemically go through your body, the immune system doesn't mount an immune response to it. Rickettsia you get from tick bites, and it's often associated with Lyme disease, and more recently borreliosis or Lyme, and all the current infections, which I'm starting to see a lot of. Currently I have 300 patients that we're treating for borreliosis and Lyme in my clinic, which is a fraction of the number of people in Australia with this. Half get it from overseas, half are getting it here. And my work at Sydney University is we're not finding positive ticks with borreliosis, but we've definitely got positive patients with all the labs, including the Australian labs, finding positive tests suggesting that borreliosis is here in people who have not left Australia. So this nonsense about this disease not existing in Australia is absolute rubbish. It's here, you've got to be careful with tick bites, but most people who get tick bites will not get borreliosis. It's endemic, it's not epidemic. So it's embedded in the community. So and we need to look for it as physicians. Now, I do a whole lot of tests to try and understand, because people have got all these vague symptoms and unusual things, and it overlays every specialty of medicine. 3-hour glucose tolerance is really useful. If you're getting hypoglycemia and you've got insulin resistance, you're putting on weight around the middle. 60% of fatigue patients will put on weight, they'll get fat around the middle. They're leptin and they're insulin resistant. So you do a test to test for that. You do 3 hours, because it's 2 hours, they're going hypoglycemic. The sugar level drops to 1, and they start to feel faint and going unconscious. That's what's happening every day in their life. So it's important to do the test for long enough. All these IgG subsets, another thing that's a test of your immune function. And many patients are deficient in some of the subsets. There's 4 subsets, people are deficient in these subsets. So these are basic, simple tests that can be done by any lab. Thyroid tests are really important. Reverse T3. It's important to look at the inactivated form of thyroid hormone, which is why many of you are cold. If you're not activating your cells and your T cell, your thyroid receptors on every cell is not being activated by active liothyronine, and it's being bound up with a deactivated RT3 or a DT3, which is a mirror image chemical, blocks the receptor but the cell doesn't work, your body will feel cold. So often you'll feel really cold. And if your body's cold, you've been dropped in Sydney Harbour or in the Yarra for 30 minutes in the middle of winter, you'll have hypothermia. And that's why your body's cold. You are hypothermic. And all your enzyme actions occur at 36.3 to 37 degrees. But you might be 35 degrees all the time. So nothing is going to work properly. These are cellular dysfunctions. Candida antibody, DHEA, pituitary hormone levels, sympactory activation tests. These are more specialised tests, but they're useful. Because some people do get failure of their adrenal glands as well. They get pituitary failure. Now, as I said, I know a lot of you aren't doctors, so I'm trying to make this, I want to get to more meaty things down the track, but these are the common tests that I will do, 24-hour Holter monitors. Let's see what happens to people's hearts when they're missing beats and skipping beats and having fast pulse, slow pulse, dropping their blood pressure. I measure their blood pressure over 24 hours as well. It's not covered under Medicare, but it's useful. A tilt table test, you're lying flat and your body comes up while you're strapped in a position, you go unconscious within 20 seconds, you've probably got POTS, postural orthostatic tachycardia syndrome. In the case study I'm going to present, the patient had that. That needs to be managed. People I see coming in stretchers lying flat, they can't get up because as soon as they start, they go unconscious. The whole pulse rate's 160, their blood pressure's 60 or nothing. It's a dysautonomia. It's part of the disease. Feces, blood tests, and one of my colleagues here, Henry Buck, does a lot of this work for me and for my colleagues, highly useful because your bowels get disturbed, your bacteria don't get disturbed. Sometimes it's if you have gastrointestinal chronic fatigue syndrome, you're in trouble because that's probably the most serious form of this disorder. And then gastric emptying studies, which is to see if your stomach's got gastroparesis, weakness of the stomach. Colon transit studies to see why you're constipated, see if your bowel actually works. And as I said, hopefully there'll be a copy of these slides later that you can all have and take with you. Now, this is just this little pie chart, and it sort of looks at PCR testing, and it's interesting, this big one here, that is when I did PCR testing. This is looking at a few hundred patients. I'll show you. This was done a few years ago in the noughties sometime. But 70% of my patients had mycoplasma. That is the cause of chronic fatigue syndrome until proven otherwise. Then there was others. This study I was looking at Giardia. I was getting a lot of New Zealand patients. Giardia, we were able to do PCR on Giardia. And then there was Rickettsia and Chlamydia pneumoniae. And these are common bugs that are present in our community, but if you're genetically or susceptible for some other reason, they can cause intracellular damage, or with Giardia you get malabsorption, disturbed gut function, and you get chronic fatigue syndrome. Okay, so here's all these common things that I do. These tests are really important. You need 30% of the population carry the celiac gene, full stop, in Australia. 60% of my patients have gluten sensitivity syndrome if you have chronic fatigue syndrome. It is toxic, it is poison to your gut, and it's not because you're celiac, it's just because we've hybridised the wheat so much that the gluten levels are so high that people are reacting to it. DHEA is often low because you've got a disturbance in your adrenal function, but also the activation of the adrenal from your pituitary is disturbed, so it's part of that endocrine disturbance. Temperature chart's really important because I need to know if your body temperature is cold or high. If you're getting spiking fevers 3 times a day, that's more likely to be an active but quiescent infection that's just sort of there but your body's not recognising it. But if your temperature is low, as it often is, in some of my patients their temperature is 33 degrees. Now that's not compatible with life, but people live chronic fatigue syndrome with these really low body temperatures. And invariably I'll find they'll have low iodine and they'll have high levels of reverse T3 but normal thyroid function tests. And a colleague of mine in Canada, Byron Hyde, he takes ultrasounds of the thyroid, and the thyroid is often very small. So some patients just have a congenitally small thyroid, and they're more likely to go into some hypothyroid state. And if you start actively producing this reverse T3, the D form of the inactive or activated form hormone binds to your receptors on your cells metabolism slows down, and it's a stress response. It happens if you're starving or you're anorexic or in a concentration camp. That's why people survive concentration camps, because they're able to slow down the metabolism. But if it doesn't turn itself back on again after some stress, then you'll have a fatigue syndrome, a fatiguing illness. Okay, leaky gut feces tests. So I do an intestinal permeability test, which is highly useful. Bioscreen or some of the other labs do my feces test. I'm looking for parasites. I'm looking for normal bacteria in the gut. I'm not just looking for abnormals. If you have a disturbance in the bacteria in your gut, you don't metabolize your food properly. And bioscreen is highly useful for doing the test, especially down here. Pathogenic cultures, so I culture everything. If it looks like it could have an infection, so it's PCR test, I'll look at urine, I'll look at sputum. I'm trying to find any cause that I can treat so I can actually start working to try and how do I get this patient better? Lactate pyrrole test, that's more to do with a test, that's a simple test where you basically have a blood test done without a tourniquet. We measure your lactate pyrrole levels, and they're often elevated if you've got fibromyalgia. And when you go 5-minute walk around the block, the levels are extremely high, sometimes 8 or 9 times normal. So what's that about? That's because you're not metabolizing the lactate, and that's causing muscle pain. It's like you've run a marathon, but you haven't, and that's why you've got pain. So lots of fibromyalgia patients have lactate inflammation of their muscles, which is why you get the taut bands, the shortened, contracted muscles, which you see in fibromyalgia. Genetic testing, which is I'm really interested in at the moment. I'll talk about the genes that I've found that are related to chronic fatigue, and they come up all the time. So the Human Genome Project is where we look at the human body, and we now know all the genes. Now some of you will have these predicted genes, which makes you much more likely, and your children will get chronic fatigue syndrome or autoimmune disease because you carry these genes. And it's preventable. It's not, just because you find something doesn't mean, you're doing it. It just means you need to look at that and use that as a treatment direction, work out what you're going to do for people. CD57, now those who've got Lyme disease might know about this, but this is a natural killer cell that's diminished in people with infections chronically. It's very low in most of my Lyme patients, and some of my Lyme patients, 0, not measurable. It's a natural killer cell that should be between 30 and 730, and often their level is 0. But in other forms of chronic fatigue that are not Lyme disease, it's often low. The other thing is vitamin D. There's a colleague of mine that I've done a few lectures with, Trevor Marshall. Some of those, he may have done the Marshall protocol, and I've been using that protocol for about 12, 13 years. Highly useful in those select patients, and have to be very careful as a physician not to make them worse. But what he says, and this is validated by my research, 25 OH vitamin D, which is the normal one we measure, is upregulated. In other words, it's converted through the kidneys to 125 vitamin D, and it's often very high. It's an indication of infection or inflammation to a proven otherwise. So you might have if your doctor measured your vitamin D level and it's low, it's not really low at all. It's been converted in your kidneys to this other form, and the other form, 125 vitamin D, is extremely high, and that's a sign of infection. So it's a predictor blood test that I use, the CD57 and 125, to tell me if people are getting better. So there's all sorts of things, little tricks that I've learned from treating 3,500 of them. You pick this stuff up and you go to conferences and I meet people and I glean it and put it all together. Because primarily I have to teach this, not just to the patients, but to doctors to think really broadly about what we're dealing with. Now, these next 3 slides are the most important slides to take out of this meeting, because this is the cause of chronic fatigue syndrome. Okay? And all these all overlap. So this is something that I put together to give us a really clear understanding. What are we dealing with? Most people with chronic fatigue syndrome have post-infective chronic fatigue syndrome following a virus. And who's had glandular fever and got chronic fatigue syndrome? Lots of people. But it's not, sometimes it's glandular fever, but most of the time it's not. It's an activator of something else. Most of the time, people have mycoplasmas, hominis, fermentins, pneumonia, all these variations of these very simple, atypical, cell wall deficient bacteria that live inside your cells and disrupt the function of the cells. Chlamydia pneumonia does the same, which is implicated in single vessel heart disease in men and MS. And I'm sure it is. I'm sure there's lots of bugs that get into our bodies that disrupt our body function, and that's what makes us sick. And we're not able to recognise them. The second most common cause that I'm seeing now is borreliosis or Lyme disease. Now, as I said, this is in Australia, categorically 100%. If people say it's not here, they're ignoring the facts. And that's controversial, but it shouldn't be. But the trouble is, most doctors rely on evidence-based medicine, and evidence often is delayed, and chance favours the prepared mind. So if you don't look for things and think broadly, this diagnosis will be missed all the time. If you've had anything that's bitten you, or you've got an unusual syndrome, which can be catastrophic, leading to death, so you don't want to really have Lyme disease in some form, so it's a serious infection in the acute phase, but look at the chronic phase, it's just like chronic fatigue syndrome, or autoimmune disease, or madness, can be just, or MS, or motor neuron disease. Can look at looks like all sorts of things. And so it needs to be thought about in the differential diagnosis. And Lyme disease, and the research I'm doing, is that the tests that we do in Australia just are always going to be negative. We do what's called an ELISA test. It's a waste of time. It's a late changing test. It does not become positive until well into someone's had 6 to 12 months of treatment. So PCR testing on urine, blood, serum, really important. You find fragments of the organism. And there are labs in Australia and overseas doing this, and Western blot, where you're looking for a reaction to the antigens, the actual structure, individually, and that's much more useful. In our Sydney University study, we've studied 180 patients with known Lyme disease, and we've almost got them all positive. And the testing kits we use in Australia are for a form called Burulidophorai sensor stricta, and that's in America. We don't have that organism here. We're integrated step. We have Zeli and Guiani, which are European and Asian types of Lyme disease, and the tests we do for those are positive. The tests for Burulidophorai that we do at Sydney University are generally negative. So we're dealing with the wrong organism, we're testing the wrong organism, which is why the labs here aren't finding it. We need to change the way the labs look at it, and that's what we're trying to develop at Sydney Uni, a set of tests that would be useful to diagnose this most deadly and dangerous condition. And I've got so many sick people with this, really sick. The sickest of my fatigue patients had Lyme disease. Now, gastrointestinal chronic fatigue syndrome. Now, to me, this is the worst type of, and all these overlap, don't get me wrong. I mean, I'm not saying they're all categorised like this, but this is how I try to think. What do I need to treat first? But if you've got chronic diarrhoea or severe chronic constipation, gastroparesis, paralysis of the stomach, bloating, wind, weight gain, weight loss, pain, all sorts of gastroenterological disturbance, you have a serious problem, often malabsorption. And my life-threatening patients have this condition. And I wrote a paper back in 2005 on very severe gastrointestinal catastrophic chronic fatigue syndrome, which are those people who waste away, go down to 30, 40 kilos, can't eat, and they die from metabolic heart failure. Very serious form of chronic fatigue syndrome. Often told they're anorexic. It's just nonsense. It's a disturbance of the gut flora. And those patients have an enormous leaky gut. They basically have perforations of the bowel, and things just leak through, and they can't metabolize or absorb their food properly. And there's a colleague in America, Professor Alessio Fasano, who's doing lots of work on this and agrees with these thoughts. Endocrine chronic fatigue, I was talking about the low body temperature. So you can have hypoglycemia, problems with insulin resistance, leptin resistance, which is where you can't actually use your body fat even though you're on a diet. And you basically stay overweight, which is why people can't lose weight when they go on weight loss diets. Adrenal insufficiency, right through to Addison's, which is failure of the adrenal glands, I see it all. And the problems with the thyroid, and as I said, I mentioned. Now, sleep dysfunction. Major problem with chronic fatigue. And look, most people with chronic fatigue will have these, but what I'm trying to do is say that if you look for the major problem, you treat the major problem, and then you'll find the patients may, you as patients may well get better. So if you've got sleep disturbance, you may well need some melatonin or something to aid your stage 3 and 4 sleep because it's going to be disturbed. And then the example I give at the end has a lot of these things exemplary. It talks about what I did for these patients. The autonomic dysnomias. Now this is a huge area. How many of you with chronic fatigue syndrome have cold hands and cold feet? you'll have a dull brain, because your brain, there's this test called a SPECT scan, so you can actually measure the cerebral blood flow, and it's diminished in chronic fatigue syndrome. You haven't got dementia, you've just got reduced blood flow, so your brain doesn't work. When your hands start to warm up and your feet warm up, usually the circulation to your brain is warming up. It's actually caused by constriction of your arterioles, the little blood vessels that provide blood to those organs. And it's a dysautonomia, it's an abnormal response. And it can be in the middle of summer and you've got freezing hand. I call it the dead fish hand. You feel like an old bit of leather jacket or something, sweaty and freezing. It's not normal. And some people get what we call brain aches, literally where they develop autoimmune disease and their fingertips start to fall off because of the lack of blood supply. So it can be quite serious. The postural hypotension, the low blood pressure, and then the POTS syndrome. Fast, hot, really high pulse, totally collapsing, and as I said, I'll talk about that in a minute with this example I'm going to give. Neuropsychiatric chronic fatigue syndrome. Who's got chronic fatigue syndrome? How many of you have been told that you've got an mental illness and you put it on? It's funny, isn't it? If a doctor tells you that, don't believe it. Thank you very much. Pay your bill and leave. Because it's wrong. It's totally wrong. You may well have emotional symptoms. You may well be mentally affected, but it's part of the disordered functioning of your body. So it's not the cause of the problem, it's part of the problem. Your brain is just another organ being affected by this catastrophic illness that's affected all of you. So you may well have anxiety, depression, obsessive compulsive disorder. And I'll come back to that in a minute because I'll talk about some of the gene studies I'm looking at. But, rarely, I think I've seen 2 or 3 people that I regard as having mental illness, which was just mental illness and chronic fatigue syndrome. And that's out of 3,500. It's not common. But all of you will have depression to some extent because it's bloody depressing having chronic fatigue syndrome. It's also, and you may well have anxiety because you've got to get from one place to the other, bedroom to the bathroom and back again. You've got to interact with someone. That's part of the dysfunction in your brain. And all this cognitive stuff, poor memory, poor concentration, thought block, you're in the middle of a sentence and you can't remember what you were saying, or you talk about something else. And I watch my patients do this, so I watch them really clearly to see if they're actually improving. The genetic disorder, also fibromyalgia. Now fibromyalgia, the only distinction I make with fibromyalgia and chronic fatigue syndrome is that the pain is dominant as opposed to the fatigue is dominant in chronic fatigue syndrome. The pain is dominant, and most of these patients have raised lactic acid, and they'll have a dysfunction in their lactic acid pyruvate studies, pre and post exercise, and you need to treat that. And I won't be going into that today, but fibromyalgia is bloody difficult to treat because these people are really suffering. They're in terrible pain. It's not in the head, it's in the body. And often I need to use strong analgesics. You may well need to use some drugs or some way of blocking the nerve pathway, so you have neuropathic pain, nerve pain without a cause, so Lyrica and all these things that are provided. But not a single thing is going to help fibromyalgia unless you treat the cause. In fatiguing illnesses, you need to palliate the symptoms and treat the cause together. If you don't palliate the symptoms and you just treat the cause, people are not going to believe you because it's such a long, slow process, as I'll show in my example. Genetic disorders, really important. Now, the most debilitating misgenetic disorder I see in the catastrophic chronic fatigue patients is the mitochondrial disorders, which I won't go into now, but this is genetic disorders, Malus and Menji, and I'm working with a professor of neurology in Sydney, and we're doing muscle biopsies and looking at these patients. This is really rare, but it gives us an insight into what's happening to your body, because it's mitochondrial dysfunction that is chronic fatigue syndrome. It's a cellular disorder. That's why you've got the fatigue. The fatigue is just the thing that you cope to deal with all these catastrophic symptoms that are affecting all parts of your body. And the fatigue is the last thing to go, unfortunately, when you've got chronic fatigue syndrome. So it's hard to treat, but the fatigue part, but if you get everything else better, then gradually you'll recover, because you can become so deconditioned. Now, Marfan syndromes, Ehlers-Danlos syndrome, all these connective tissue disorders. I see enormous number of patients with these conditions, which they're born with, where they've got disturbances of their collagen and the way and they can do all funny things with their arms, the Indian rubber man type people. And that's part of the condition. They're predisposed to get chronic fatigue syndrome. I've been doing some work with celiac gene. As I said, 30% of the population, 60% of my patients will have gluten problems, and many of them, more than the percentage in the community, will have celiac gene. Pyrrole disorder, they're highly controversial. Pyrrole is a chemical that's produced from the breakdown of heme, which is a part of hemoglobin, which you carry in the oxygen, which carries your oxygen around your blood. When it breaks down, it normally goes into bilirubin, which is what makes your Dalmatian brown. But if it goes to a pyrrole, it'll stop you taking up zinc, biotin, activated B6, and omega-6 fatty acids. And then that will affect your nervous system. That will affect so much of your body functioning. So 10% of the population carry this pyrrole disorder. Again, it's an emerging syndrome. Most doctors don't know about it. It's controversial, but I can tell you it's about 40 or 50% of chronic fatigue patients. And the other thing called the MTHFR gene, 10% of the population have a homozygous, have two alleles for this disorder. It's an undermethylated disorder, so you don't activate your B12, and again, zinc's implicated. How many of you with chronic fatigue syndrome have low zinc? Probably all of you, if it's measured. Right? You need zinc for lots of immunological functions, for brain functions, for immunity, and you'll have it low. And if you measure your MTHFR gene, you'll have to pay for the test. Homocysteine, you do a pyrrole test, which are all available in Australia. You might be surprised, especially if you've got some of the emotional, behavioural problems. I also see it in my autistic. We have 1,000 kids with autism that we treat in our clinic. Apart from 3,500 chronic fatigue patients, we have a few thousand autoimmune disease. I mean, we're 35,000 patients over the last 20 years, a lot of patients. So we've got a really good, clear view of these things occurring commonly, keep popping up. The genes determine the effective, lower your immunity and make you at risk of getting these disorders. And you can do things to modify the genetic expression, and that actually helps people get better. Now the last one, which you wouldn't think, is surgical chronic fatigue syndrome. Now this comes from observation. The most common one is something that's infected and it's been there for a long time. Gallbladders, chronic cholecystitis, chronic appendicitis, chronic tonsillitis, wisdom teeth, right? If you've got diseases in those organs, you need them removed, because what I find is you take them out and lo and behold, you start to get better because it's immunologically lowering your resolve. There's a rare condition that some Americans seem to say that was common called Arnold-Chiari syndrome, working with a fellow up in Sydney, Charlie Teo, and he's been cutting holes in the back of people's heads to relieve the pressure on the brain. And the Arnold-Chiari syndrome, which is where you herniate your brain because of increased brain pressure, puts pressure on the back of your brain, and you get chronic fatigue syndrome. Myalgia, muscle pain, collapsing, and brain fog. That's rare. But I mean, you still need, as a physician and as a patient, you need to think about these things, and it's picked up by MRI scanning. So, as I said, these slides are the most important, and most people don't just have one of these things. I just created this nomenclature to try and help people understand how complex this disorder is. And some people will have 5 of these. There'll be 5 things that in that group of suggested thought process categories that my patients have. Now I've got to watch my time, so I want to get on to question time and give you this overview. Okay, so this is an interesting slide. This is, now as I said, I've treated 3,500, so I just took 300 patients at random from 2004 to 2013, and I test all patients for infection, because that's what you've got to look for. And lo and behold, what's there? Mycoplasma, 157 out of 300. Okay, chlamydia pneumonia, 11, rickettsia, 7. Lyme disease was only 21. Then there was all the parasites, candidiasis. Now candidiasis is an overgrowth of a fungus that naturally women obviously know about, thrush, and babies get thrush. But if you get it in the gut, and it's often one of these atypical forms, glabrata or cruciole, these are really serious manifestations of illness. The woman I first treated with chronic fatigue syndrome had Candida glabrata. It's always pathogenic. If you find it as a physician or your doctor says, look, I found Candida glabrata on a vaginal swab or an oral swab or something, you've got a serious problem. This is a nasty fungus that can actually override your bacteria in the gut and cause chronic fatigue syndrome. And then there's others, 81. Now, out of this 81 down here, since 2013, I've retested a lot of my patients. 4 out of 5 have Lyme disease. So I'm now starting to see this complex illness behaviour in lots of patients that is due to infection. Now, not everyone with chronic fatigue syndrome has infection. There are lots of other causes and lots of other things, and not all my patients go on to antibiotics, but it's a fair number. Okay, we'll keep going. Okay, so this is just a simple slide to show what I thought was the most important diagnostic symptom or group of symptoms, just to give you an understanding of what's number one. Look, the most common category was the genetic disorders. People who carry certain genes are going to get chronic fatigue syndrome more frequently, which is why your children get it, why your mum had it, why your cousins have got it. Right? So you may well start to find some of these genes that I mentioned and others. I'm only touching the tip of the iceberg. I'm now just starting to do gene studies on all my patients, trying to understand why they're sick. And then there's sometimes neuropsychiatric with 3. I definitely have people with mental illness presenting to me with fatigue syndrome. 2 of those actually had Lyme disease. I treated them with triple therapy antibiotics for 12 to 18 months. They now don't have psychosis. They've had it for 20 years. They're off all their medication. So, because, and it's just because they got tick by it and developed mental illness. And no, we're from America, mind you, but you've got to think about it as a physician. And then these others, the sleep disorders, common, and the endocrine, high endocrine. Now, 30% of you in my books will have thyroid disease. But according to Byron Hyde, there's a colleague doctor in Canada, he says 50%. So I just haven't, he's in his 70s, late 70s, so he's been practicing longer than me. So eventually I'll see most of you, 50% of you probably go into that, because I think it's right. It seems to be such a common problem. You'll have low body temperature, high levels of reverse T3, and 30% of you or so will actually go to Hashimoto's thyroiditis. So you'll actually develop autoimmune disease. 30% of people with chronic fatigue syndrome will go into autoimmune disease. You'll get rheumatoid, you'll get thyroid. Sorry to be a downer, but this is what I've been observing. So, but you can reverse that process by treating the underlying cause. Okay, I'm not going to go through this, but these are the antibiotics I commonly use. My favourite antibiotics is doxycycline, Milstat, and azithromycin. And I treat people for long periods of time, which is controversial. But there's a colleague of mine now in Sydney, Professor Andrew Lloyd. Lo and behold, he's going to do a 6-month study on chronic fatigue syndrome using doxycycline because he's heard that it works. And I've been doing this for 20 years, and in discussing with him, he says, no, you can't do that. But you can do that. Some of these drugs you've got to be very careful with, you've got to be extremely cautious you don't get the resistant bacteria and other things, but I don't seem to find that. Doxycycline is used worldwide for the prevention of malaria. People are on it for 5 years. Don't take protection like Milstat or probiotics, just take it. And they seem to be okay. And these antibiotics are useful in getting people better. Treat the cause, treat the symptoms. Okay. Prevention of fungal infections, I use all the different antifungal agents. I use probiotics, which I won't go into. And as I said, hopefully there'll be access to those things. Okay. Then there's a whole lot of supplements that you use, which I won't go into. I definitely use a whole lot of hormonal treatments, amitriptyline, which is painkillers sometimes, whatever it requires to treat the symptoms. And the POTS syndrome's got the vascular stockings and whatever. And I use lots of ancillary practitioners. So I've got a counsellor, I've got osteopaths, I have exercise physiologists, I have a whole great team working with me to rehabilitate you back to health. It's difficult. I don't have all the answers. I can be the director of management. And who does most of the care? The carers, the families. How many parents come in with their child who's 35 to a consultation? Well, in my world, that's common. A 35-year-old person, your parents are there telling you a story, and you're too sick to tell the story. So it's difficult. Okay, in my practice, 50%, when I say significantly improved, all intents and purposes, they're as good as I'm going to get them. You will be damaged, and you probably won't fully recover from chronic fatigue syndrome, but by God, you get better. If you treat this properly, you can recover, have a pretty well normal life. You may have to pace yourself. You may have relapses if you do too much, but by God, you can get better. So when you read stuff on the net, you don't get with chronic fatigue syndrome, again, Don't take that on board. That's not true. They're not looking hard enough to understand why you're sick. 20% aren't improved, 10% get worse. Now either I'm treating the wrong thing or they've got something that's catastrophic that I'm going to really struggle with. They've got neurological Lyme disease or they've got mitochondrial disorders. So some of these things that basically are progressive anyway. Okay, my conclusion is, and I want to give you a case study and then I'll answer your questions. So chronic fatigue syndrome, fibromyalgia, is a very complex and distressing disorder. The most important aspect of treating this disorder is accurate diagnosis and commitment to long-term management. I'm still managing patients back for 20 years. Okay? You have to find a committed doctor, naturopath, but preferably a medico who's got a broad brush of treatments and thought processes to manage you. In my experience is the most important people who talk to me about all this are my patients, not other colleagues. I don't read this on the journals. I don't see this stuff. This is my stuff because this is what I'm learning. I glean it all together. Okay, so let's move to a case study because this is probably exemplary for all of you. Now, this young lady, we'll call her Nikki, age 19, she presented to me with recurrent infections since birth. Glandular fever at 15, followed by classic chronic fatigue syndrome. Every symptom known. From February 2008, she had constant headaches, lightheadedness, visual changes, swollen glands, shortness of breath, fast fluttering palpitations, constant diarrhea, lactose and fructose intolerance, severe myalgia, arthralgia, dermatitis both arms, heat sensitivity, cold hands and feet, severe sleep disturbance, circadian dysrhythmia, sleep paralysis, night bears, unable to walk 10 metres at a time, severe obsessive compulsive disorder and severe cognitive dysfunction. Classic chronic fatigue patient of the severe type, okay? Very sick. Seen about 20 doctors before she got to me. Family history of acne rosacea, and look what's there, OCD, there was a history of that, Raynaud's phenomena and Sjogren's syndrome. So there's both autoimmune and behavioural problems present in the family. Genetics. I didn't do an MTHFR and Pyrrole disorder test on this girl. I wasn't doing it then, but she'll have both. Now, she was in a wheelchair, she weighed 45 kilos, she had dead fish hands, pulse of 100, blood pressure, she'd stand up and she'd collapse and go unconscious, heavily coated tongue, lymphadenopathy, she was cyanized. She had functional cardiomyopathy, a weak heart. Tender muscles and joints, and she had all the torque bands, so all the muscles were rigid. You touch her and lightly she squeals and squirms and very uncomfortable. We did a sleep study on it. She had 130 arousals over a 4-hour period. So that's quite severe, you know. Basically, if you're eroding up every few seconds, you're not going to get a decent sleep. Temperature chart was within the normal range, except she had slight spiking temperatures. 37.4 is not normal. Celiac disease gene positive. Really important for your doctor to check your celiac gene. Her vitamin D was low. Doctors kept giving her vitamin D, but lo and behold, what did she have? The 125 vitamin D was 221. Upper limit normal was 175. Because it was upregulated in the kidney because she's got infection. Fasting insulin was 16, should be less than 10. And she's skinny little thing, so she's got insulin resistance. Gross vitamin D level was, vitamin B12 was low, she had raised liver enzymes, very low iron, very low urine iodine, really common. Chronic patients with these diseases do not absorb iodine when it's not in their diet. If you're not eating lots of seaweed and kelp, it'll be low. Thyroid function tests were up and down, feces were negative. I did do a Pyrrole, it was negative, so I'll take that back, it was negative. But I did a PCR test, and what did we find? My friend, mycoplasma. Okay, she had an OPG, she had dental pain, and severe impacted wisdom teeth. She had polycystic ovaries, but not polycystic ovarian syndrome. Gastroscopy was negative, and a tilt table test I didn't do because she was too sick. You put people at risk when you do some of these tests because she was going unconscious standing up. I didn't think I really needed to do a tilt table test on her. So my diagnosis was chronic recurrent infection since birth, post-glandular fever chronic fatigue syndrome, mycoplasma infection, POTS, obsessive compulsive disorder, polycystic ovarian syndrome, so she probably did have the syndrome, chronic wisdom tooth infection. So first thing to do is educate the family, because by the time people get to me, they've been told all sorts of nonsense and things that aren't true. She's putting it on. She's conversion bench. All this nonsense you hear out there bandied around by doctors and other psychologists and people is wrong. These are not, these are physical problems with pathological basis. Gluten-free, put her on a gluten-free, high-protein, low-carb diet for the insulin resistance and the gluten sensitivity. She's not celiac. 2 to 3 litres of water with iodized salt, lots of salt, and quite a few supplements which I won't go through, but including iodine and iron and magnesium, all the big CoQ10, probiotics, fish oil vitamins, multivitamins, and weekly B12 injections. For sleep, I put her on amitriptyline, and those who might know it as Endep, very low dose, quite very safe drug. It regulates the stage 3 and 4 sleep with melatonin, which I've used for the last 20 years. Yes, it is available here in Australia, and you can get your GP to give you scripts. Clonazepam, very good for stopping the seizures that people get. So it's used as an anti-epileptic. It's Rivotril is its other name, but it's highly addictive in big doses, but little doses will reduce some of the symptoms, especially if you're getting the twitches and the fasciculations and all the body movements that people get. And sleep hygiene. Get her into light, get her into dark at night. Try and regulate her disturbed sleep. Short leg stockings to increase the compression of the legs to elevate the blood pressure. All patients with POTS need to be wearing short leg compression vascular stockings, grade 1s. Lightweights, walking with a pedometer, therabands, graded exercise, cognitive behaviour therapy, what we hear from my colleagues. But that's an end stage treatment. That's not in the beginning, it doesn't help in the beginning. And of course there is a range of medications. My favourite, doxycycline, Nelstat, proton pump inhibitors, metformin, midodrine. Now midodrine is a drug that constricts the blood vessels, elevates the blood pressure. Most doctors won't use it, but it's available. You just have to order it through the government and you can get it. Put on low dose of Lexapro. Now Lexapro is really useful. That's an SSRI antidepressant, but it's been shown to help with POTS. So it helps stabilise the irritated heart and stops the dropping of the blood pressure. She was on some gabapentin, which helped her OCD. Yes, I'm going to stop now. Couldn't tolerate fluorocortisone, adrenal extract, tried the adverse, tried the pill, and that didn't work. So, how did she go? Well, this girl was pretty sick from 2008 to 2009. Then we took I give anaesthetics for my dentist. I have a dentist in my practice and a prosthodontist, a hygienist, because you've got to keep your teeth clean if you've got this disorder. And we took out the wisdom teeth under midazolam sedation because she was too sick for a general anaesthetic. And lo and behold, she felt much better. She had a surgical problem with her teeth. It added to the complexity of her illness. And from 2008 to 2010, 2 years, 2.5 years, she was on antibiotics. I have no question about putting people on these long-term antibiotics. They work. February 2010, no sign of OCD. POTS was up to 55 kilos. Remember, she was 45. In 2010, she moved out at home, walking daily, no symptoms of chronic fatigue syndrome, only taking clonazepam and melatonin to sleep. And I continued to see this young girl, and I just saw her recently. She came in for a checkup. She's now doing social work, and she wants to work with disabled people. She's on a low-carb, high-protein diet, olive leaf extract, cod liver oil every day. She's on a gluten-free diet. Examination was normal. All the pathology was normal. All that stuff that was abnormal before, we repeated, was normal. She's driving, has a boyfriend, very important. The signs of recovery is you've got a life. You've got friends, you form relationships, you can study and you can work. They're probably things that are right for all of us, but you've got chronic fatigue syndrome, all that's taken away. I expect her to fully recover and have a normal life. And she was reviewed only in May, and she's fully recovered and happy and getting on with life. And no sign of OCD, none of this stuff. So to go away with this, I think what I've tried to do today, and it's very quick, is to give you an idea that this is a complex disorder with multifaceted problems. Treat the cause, treat the symptoms, and you've got a good chance you're going to recover from this illness. And if people don't believe this is complex, or they're saying it's conversion reaction, or you've got a mental illness, they really don't fully understand what's wrong with you. Your symptoms are a result of cellular damage, and that cellular damage is you're predisposed to because of your genes and because of the things that are infecting you or affecting you. The way your body dysfunction is causing those symptoms. And you've got to treat those to get you better. Thank you.
Absolutely amazing.
Yes, I'd like to ask whether the treatment that you have at your clinic in Sydney, is it available anywhere in Victoria?
No. There are excellent doctors down here in Victoria, but they're few and far between. So I think each clinic has its own flavour. You know, there's Don Lewis, Don Higgins. No, Don. There's a number of doctors who are treating us in Victoria, but they're few and far between. So, but this is consensus treatment. When I go to conferences, this is what we all talk about. So if I go to the States or Europe, or meet doctors from those areas, and we have conferences here, we talk about the complexity of these treatments. So this is, but there's not a lot of doctors that I know of in Victoria doing this sort of work. We're not unique in Sydney, but we're probably one or two clinics that are doing this.
Do you have a list of doctors who are doing it in Victoria?
No, my staff might. You'd have to. I really don't know.
Sorry, Emerge Australia has a list of health professionals that are sympathetic as well as knowledgeable in treating, diagnosing and managing. So please contact us.
Thank you. Could you comment on low-dose naltrexone for symptom relief?
Yeah, low-dose naltrexone. Now, naltrexone is a drug we use to prevent people relapsing with drug addictions and alcohol. And we usually use 50 milligrams a day. Now, if you use between 1.5 and 4.5 milligrams a day, theoretically it blocks some of the receptors in the brain, and there may be an immune activation process that some people claim they respond to. My experience with this, it's only effective for a very small number of people. I was trying it over the last 20 years. I probably have about 20 patients on it, but my experience is as soon as you start introducing, especially if they're on painkillers or they're taking Panadine or anything else, a lot of these effects are nullified. But it's definitely some of my sicker patients have benefited from it, but it's not something that I would use I don't use any single entity treatment. It makes a lot of difference. You've got to treat the whole person. But that low-dose naltrexone may have an effect. It's worthwhile trying, but many of my patients actually got much worse when they took it.
Hello, my name's Kate Strasser. I'm a GP here in Melbourne. Thank you for your time today coming to Victoria. I've got two questions in particular. One is the doxycycline,
Yes.
Both the dose and the length of treatment, given that 100 milligrams would be the more common use, for example, in something like malaria prophylaxis.
Yes.
So why the 200, and also the length of treatment?
Okay.
And the other question I've got is I've got a 22-year-old woman who had severe glandular fever last year, resulting in liver failure and needed to be hospitalised. She now has quite severe chronic fatigue. Should I be looking for other infections in her?
Okay, well that answers those questions. Now doxycycline, you need a level of, the blood level needs to be sufficient for this intracellular tetracycline to enter the cell. So I use 200 milligrams standard dose, but it'll vary. Some people are on 400 milligrams a day, but most people are on 200 milligrams, but you amplify it by using azithromycin or Zithromax, 500 milligrams once a week, and that'll amplify the effect fourfold. And the very nature of doxycycline is it can cause nausea and photosensitivity, so you've got to be careful not to get sunburn, but incredibly well tolerated, except in those with pulmonary pneumonia and gastrointestinal chronic fatigue, which tends to make the problem worse, probably because it's irritating the stomach or causing more disturbance in the bowel. For the lady who's had chronic glandular fever and hepatitis, look, the most common cause of hepatitis amongst young people in Australia is glandular fever. It's a really serious complication of this disorder, and you've got to be very careful because most antibiotics are metabolised through the liver. So in this young lady, I'd be using glutathione to try and help her detox and vitamin C infusions.
Certainly her liver function is now quite
It may be normal, but she may just check her ferritins and just have a look at other parameters of her insulin, her cholesterol, to see if she's got signs of fatty liver. Do an ultrasound because you want to know whether she's got the physiological changes of the liver following hepatitis, because the cells will regenerate. But yes, absolutely, because I think glandular fever is an activator of this disorder. I think that's what it does. It's sort of, you know, and often you've got mycoplasma. Now, 12% of the population, according to Garthixa, have mycoplasma in their body anyway, but 60% plus have it as part of chronic fatigue syndrome. So we think it's activated by other
So the
things.
Epstein-Barr virus is not actually perpetuating
No.
chronic fatigue, it's actually
In a small number of
activating
patients. Look, some patients will have chronic active glandular fever, that Epstein-Barr virus, and there's some evidence to suggest it lays dormant in your body and can reactivate somewhere down the track. But I think really it's an activator of something else. That's what my observation is. But I would probably treat this woman initially with high-dose vitamin C, glutathione, and a short trial. If you're going to start doxycycline, start with 1 a week. But do a PCR test. Australian Biologics in Sydney, which is a non-NATO approved lab. It's only because they don't have a pathologist there, but the technicians that run that are doing the best work in Australia on PCR testing for Lyme disease, mycoplasma, chlamydia, and it's called Australian Biologics in Pitt Street in Sydney, doing wonderful work to try and elucidate the PCR testing for chronic fatigue patients and autoimmune disease, because I mean, we need evidence to actually base the treatment on. And often the evidence follows the observation rather than the other way around. That's why this is not an evidence-based disease. You can't treat chronic fatigue syndrome with evidence-based medicine. It's too complex. It's too broad. We have to create evidence by observation and management, and we'll fall flat sometimes. We'll make mistakes. But every one of you is got to be individualised in your treatment.